So today I'm joined by Lieutenant Colonel Simon Horn, who I will ask to introduce himself just now. And we're very grateful for him to giving us his time to talk about his career, both in military medicine and in the emergency department at Derriford Hospital. So Simon, could you just tell us a little bit about yourself and your career highlights to date?
So, Simon Horn, emergency medicine consultant is my primary trade with the British Army, which has led me to kind of fall into global health accidentally by a slightly sideways route. I was a traditional emergency medicine consultant, I suspect, in the military. I did tours of Afghanistan. And my training and operational focus was very much on delivering healthcare to deployed personnel. But towards the end of my time in Afghanistan, it became quite clear to me that we wouldn't be doing that kind of role again for a little while. And I'm easily bored. And so I started looking around and thinking about where the military would be going next and what that might, which bits of that I might be more interested in. And I think the one that caught my eye was the whole disaster relief, humanitarian support and development thread, and interestingly, the military does lots of activities in that area, but hasn't necessarily understood them and described them very coherently in the past. So I thought I would get a bit of information about it, and I did the diploma in humanitarian assistance at Liverpool in about 2014. And what was interesting about that is right at the end of the course, the chief instructor said, "I'm terribly sorry, I'm going to have to go. I can't see you to the end of the course. I've got to go out with the World Health Organization because there's apparently been a hemorrhagic fever outbreak in Guinea." And so he went off to investigate that. And unsurprisingly, 6 months later, the British Army was finding itself involved in the West African Ebola outbreak. And as you may recall, that was particularly unique, I would say, in that there was a request for military aid that actually was funneled through Médecins Sans Frontières, but the civilian sector widely, DFID, the NGOs, and clearly the West African reaching out for help, and specifically were reaching to the militaries. And so I was invited to be the medical director. And so essentially that then threw me into a world where we were working with lots of disparate organisations, some of them governmental, some of them UK, some of them national, some of them local, and also the non-governmental organisations. And again, the whole spectrum of those, from the very fiercely independent Dunantist ones to much more Wilsonian or local or faith group based ones, and it kind of moved on from there. The military asked me then to work on our training course for disaster relief, humanitarian and development type activity, which I ran for a couple of years. And when I knew that my next operational deployment was going to be to South Sudan with the United Nations, I thought this was a great opportunity to start a PhD into what the relationships between militaries and civilians should look like along that spectrum, from aid through development and into peacekeeping and peace building. And I've now ended up running the Centre for Defence Healthcare Engagement, which effectively is the advisory and research and analytical body within defence that helps us understand how to do that kind of activity better. So it's been a kind of strange gallop from the sort of 2012, very much trauma-based military emergency medicine, into a much more focused interest, where I do half of my week now looking at development in partner nations across the globe.
Wow, Simon, that's quite something to accomplish in such a space of time. And I love the idea that you just felt it was the right time to do a PhD in this work. I guess in many ways it was, because you had all the sort of practical experience there as well to gather that information. And so what were the main findings in your, both in your PhD and in your actual day-to-day work? What do you feel, what should a military-civilian relationship look like, and how do you build one?
So, like all PhDs, although I'm coming to the end of it, there's still plenty more to do. And you have to draw a line somewhere, but I won't have all the answers. But I think if you break it down into a couple of key areas, there are some truths, if you like, that we can work with. I think the first one is that militaries and civilians are going to meet in war. That's where the whole basis of international humanitarian law has come from the original Geneva Conventions and everything subsequently. And I think that part is generally pretty well understood, the relationship there, which is that militaries should stay out of the way of civilians. They should ensure that they're not targeting or harming the civilians. When they are the best placed people to do so, then they may be required to provide aid to civilians, and there has to be a relationship with NGOs and other organisations as part of that. And now that might be simply complete coexistence, where the civilian organisations are doing their thing, and we just make sure that we don't tread on their toes and we avoid any conflict with their activities. So we know where they are so that we can stay out of their way. That's at its most simple level. At its more complex level, if we do reach the stage where there is an occupying power, but there's an area of a lot of conflict, such that the humanitarians can't easily move around, or it's too dangerous for them for that time window, then the Geneva Conventions actually say that the occupying power has a duty to provide healthcare and public health services, amongst other things, in that context. So the relationship is always going to be fraught, because militaries will be fighting and causing casualties and causing damage, and clearly humanitarians are simply trying in that context to alleviate that suffering. But I think the nature of the relationship is pretty clear. I think the challenge comes when you move a little bit beyond that into the sort of development space or the peacekeeping space, where again, militaries traditionally should be sticking to security-based activities, but where I think healthcare provision is often very patchy, and military healthcare workers will often feel, rightly or wrongly, that they have a lot to bring. And I think in that context, we probably do have some important things that we can share with, particularly with other healthcare workers. But in this context, I think that it's important that we always bear in mind that we are transient, and that we are not the correct face of healthcare. Healthcare fundamentally is a civilian activity. Delivered to civilians by civilians. And so while militaries do it and dabble in civilian healthcare, we need to remind ourselves all the time that we are neither the lead agency nor the experts in this. But I think there are elements where we can do significant capacity building, both within the civilian systems and within the other organisations that are providing care. And certainly in South Sudan, one of the things that was really powerful was we were asked to help contribute to the major incident and mass casualty plan for an internally displaced people camp in northern South Sudan. And that was interesting because we effectively served a bridging function, a facilitating, translating function. We had the NGOs and civilian components of the UN response, so the World Health Organization, the World Food Programme, but also OCHA, ICRC, MSF, as well as lots of national and local NGOs. All had an idea about how they'd like to do it, but they didn't have the ability to do that within that camp where the security was provided by the military, and where much of the transport and communications infrastructure that the military had was far better than the civilians had within that setting. They couldn't deliver a coherent plan on their own, but they didn't really understand the language that the military were talking in terms of how they organise and respond to these events. And so we were able to bring, based on MIMS, on the Major Incident Medical Management and Support framework, a simple framework and a common language that people would understand the concept of bronze, silver, and gold areas. They'd have clarity about responsibilities when it came to triage. They'd understand how to communicate and call out with a comms cascade. And we were able to get from 2 or 3 quite disparate plans that all had the right elements in them, but not necessarily all of the elements and not necessarily all in the right order, into something that had a single trigger where everyone knew their responsibilities and everybody had agreed what they would do. And most of that was about acting as a bridge, going to talk to the interested parties, sometimes separately, sometimes together, giving them briefings and information so that they had that common terminology and sort of framework to work to, but then negotiating the difficulties, negotiating the wrinkles about one nation wanting to have a military, wanting to have access to the MSF facility, or wanting to be able to carry their weapons in there, and being able to explain to them why that just wasn't feasible and wasn't possible, and show them how they can get the same effect in terms of security without having to tread on MSF's toes. So I think there is a space for military medics there, but it's probably in what OCHA, the Office of the Coordination of Humanitarian Affairs, would describe as the bridge and lorry in their cookie lorry bridge model. They talk about the cookie, where you're handing out aid or delivering care directly to the civilians. They talk about the lorry that's part of the transport infrastructure and support to that delivery. And they talk about the bridge, which is the wider infrastructure that facilitates delivery of care. And so in our context, I think what that means is where there is conflict, the military should be supporting the bridge. And occasionally when we have to do the truck, and then the cookie is only under those very limited circumstances we talked about in open conflict where no one else can get in there. And so for what my job entails with the military in that context is explaining to them why being hands-on, being photographed, handing out aid to civilians is a bad thing, and why quietly facilitating the activities of humanitarian actors and development actors in the area so that they do a better job in the long term will give us the influence and kudos that we seek, but without necessarily being quite so visible and having a much better outcome for the civilian population. So peace building will be our sort of relationship long term with other militaries and other civilian agencies. The concepts of health being an apolitical entity that is delivered purely in the best interests of the patient, which is how it should be, clashes with the political priorities for healthcare are set by a government that has a budget. It's completely political. It's not apolitical. And I think in those spaces, militaries can work, especially with other militaries, to develop healthcare quite freely. And the sort of humanitarian principles around particularly being independent and neutral, I think are largely irrelevant when you're that far away from the conflict space.
That's really fascinating, Simon. And that, yeah, I think that resonates with so many of us who have worked in the humanitarian setting. What you're saying really resonates with us. And I guess hasn't always been the case that we have seen it that way. So that's fantastic to know that is the drive, that's the route that should be taken forward. And it must have been difficult.
Go on.
Sorry, carry on.
I was going to say the challenge now, of course, is translating that into fact. I think I think there is a fairly clear position that meets the requirements of all parties, and that's kind of where I've got to. Translating that to the point where that's what all parties try to do is obviously another big step.
Yes. that's actually one thing I was going to ask you about now, is when you say getting all parties to agree, and we know that, okay, MSF is a big player, but as you've already mentioned, there are many other NGOs out there. Yeah. And are there any practical tips and tricks, or how have you managed to coordinate, to bridge that gap between military and civilian, but also to coordinate between all the other players who were there and everyone, to bring all those different NGOs and everyone, all those stakeholders with their different agendas together to work towards that common goal?
Yeah, so I think there are a couple of elements to it that make life a lot easier. The first one is to understand where they're coming from, and so understanding the organisational philosophies is really important. And so for me, as a military clinician, to be able to talk in considerable detail about international humanitarian law and its implications and what the expectations are of NGOs and how they operate and how their systems work and what their concerns are is really powerful. It's quite disarming. And they're often very surprised and a little bit stunned when we have these conversations. And you have to match that with action. One of our challenges in Sierra Leone was the insistence that we were in uniform at all times, which made it very difficult for us to get into certain areas without civilians who were there as well feeling a little bit uncomfortable. I'm not saying that military should disguise what they are, but I think being discreet and understanding just how important the perception of an NGO's neutrality and impartiality is, by demonstrating that you understand that, by choosing or allowing them to choose the terms under which you meet, really powerful. So that allows you to open the conversation. And the same is true for other nations' militaries. Knowing where they come from, knowing a bit about their culture and heritage within their military and how they do their business helps you to start the conversations. Now, clearly, that's much easier for me because for most of them, we share a uniform. For many of them, we have similar systems. But being able to show that you understand both sides is a very important starting point. I think the next thing is to really understand what their agendas are locally and what their sticking points have been historically. Understanding what specifically they're trying to achieve and what their hopes and fears are around the situation that you're dealing with. And this is just as applicable to the militaries as it is to civilians. And so going back to that case about patients being in the MSF, effectively, it boiled down to the fact that MSF clearly don't want to be seen to be accommodating military personnel who can then walk around the facility, might be, thought to be taking photographs, scoping for people of interest, while also carrying weapons. That would really undermine what MSF was doing in that environment. At the same time, the troop contributing countries, when they're out patrolling, will occasionally have been under fire. The year there had been some Chinese peacekeepers had been killed while trying to keep fighting parties apart. And so they want to feel that they've got their normal military SOPs in place and that they're safe. But that's just simply, that can be solved easily by moving the handover of casualties 20 or 30 yards away from the facility. Once you realise that the concern of the troop contributing country is that they don't want to put their weapons down, but they can't come into the hospital unless they do, then you say, well, that's fine. All you do is you hand over your casualties 30 yards further down the road. How's that for you, MSF? Well, we don't want a sort of formal thing that looks like it's a permanent handover takeover point, because that implies we're working too closely together. Great. Okay, so we'll have an informal thing. Where would you like it to happen? And once you focus people's minds on what it is they want to achieve, rather than what historically have been the problems or what their concerns are, then you can very rapidly unpick these things and move them along. So I think understanding and showing that you are a credible mediator is the first thing. And then getting to the root of what it is that people actually have as hopes and concerns that they're trying to achieve from the conversation is the next thing. And then I think the final thing that I discovered that was really useful was getting people to focus on achievables first, and put the stuff in the too difficult box to just kick the can down the road a little bit. Initially, when we had these conversations, again and again and again, this context, this problem of handing over these patients and are we armed or not, would derail the conversation, and people would start shouting at each other. Well, last time you came, you did this, blah 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 blah, and it brought everything to a hard stop every time. And so, what we very rapidly picked up on was we needed to concentrate on steering the conversation to achieve the things that both sides did. So let's not talk about casualty handover yet, because we haven't talked about how we trigger the response yet. Let's not talk about casualty handover yet, because we haven't talked about scene management yet. Let's not talk about casualty handover yet, because we haven't talked about triage yet. And by the time you now come to how do you actually hand over those couple of casualties that are on a military vehicle to a civilian hospital, you've already agreed 80% of your major incident plan. And people are realizing that it can be done and are realizing the benefits from working together. Then suddenly that massive problem that was derailing everything at the beginning becomes far more manageable, because people are invested in it now. They've got an 80% plan that wants to work, and they now see that this is just a little blocker that they need to unpick. So I think those are the three areas that I found were particularly useful.
Yeah, I think that's right, Simon. And I think you can overlay what you've said probably to almost any situation, can't you? Whether that's in major conflict zones, humanitarian settings, or even just trying to agree your major incident plan across multiple NHS trusts in the UK.
Yeah, absolutely. And I think it goes way beyond the NHS now, way beyond major incident now. I think the biggest thing for me as an individual, the biggest growth for me for this whole process has been how I've changed my approach and adapted the way I do business within my own trust back in the NHS, because all of these things are equally true. You can't have a conversation, you can't take a meaningful part in any kind of meeting unless you are seen as credible. And fundamentally, those two specialties are competing for beds in the same hospital. They're competing for staff. They're competing for resources. And it's about showing them how between them they can move to something that's mutually beneficial, and concentrating on that element of it. And then getting down to the nuts and bolts of, okay, who has the most outliers on this medical ward? Which is the intractable problem, but getting there once you've agreed the common ground, because then people are enthusiastic about it, and they it's their plan now, and they want it to work. They want to find a solution.
Yes, I think that's very, very true. And do you feel that you could apply, obviously, the recent sort of world pandemic in COVID? Do you feel that you've managed to put many of the skills that you've learned over the years in the humanitarian setting to support the COVID response, either in the UK or internationally?
Yeah, absolutely. So on the most practical, tactical level, much of the initial response to COVID is broadly very similar to much of the initial response that we learned with Ebola. And going back a little bit further, much of that came from thoughts about flu. And okay, Ebola is predominantly contact spread illness, and clearly COVID is not. But the fundamentals of how you structure a system to manage infectious disease outbreaks doesn't really change dramatically from one disease to the next. And so that understanding and the building blocks and the approach to training was very important. I think the other thing that was invaluable from Ebola was understanding how we had instilled confidence in our staff to go into the Ebola treatment unit. What we did at the AMS, Army Medical Services Training Centre, where they would photograph you in a dark room under fluorescent lighting in your clean uniform, and then you would go in and they would use fluorescent markers within the vomit, the feces, the blood, and the environment of the facility. And then when you were coming out, you knew that you were covered in this fluorescent marker, but you would then go through the decontamination process, and subsequently they would then go over you with the fluorescent light to show you that you weren't contaminated. Now, clearly we don't go through that laborious decontamination process with COVID now, but right at the beginning, that kind of ability to give people a sense that the trust in the systems and processes they're getting involved in, that was absolutely invaluable. So the nuts and bolts of managing an infectious disease in the UK, I learned, as did many of my colleagues, from Ebola and from previous military experiences. But it was the training and the confidence and the processes that we brought back that I think were especially useful. And I think then, again, if you think about negotiations in terms of understanding what people's position is in terms of their hopes and fears, understanding what it is that is focusing, that's concentrating their attention, what's stopping them from being able to move on, and what is it that's worrying their staff. And so the leadership aspects of the military work I've done, and the walking the wards and talking to people and taking tea with them that I've done in global health and in development activities, as part of that understanding of where they're coming from, you bring that straight back into the same context in the UK, and all of those tools are just as valuable, if not more so.
I think I think that's very true. That's a really insightful comment to say, and I think that resonates with me. I often chat to many doctors, some of them actually quite junior, who have been posted out to quite rural areas, some of them in conflict zones or just outside, to smaller hospitals, and they're expected, because they're the medic, by the doctor, I should say, by default, they're then expected to lead this hospital and be involved in the management, but also support the staff and motivate, if you like. So I think what you've said there about understanding where people come from is incredibly important. Is there I know this is a difficult one to sort of sum up in a nutshell, but in your vast experience of leadership, both in the military and in the humanitarian setting, is there any advice or anything you've learned from specific leadership styles or leadership techniques of how you would approach that, as going from doctor treating patients to a leadership role?
Yes. So I think some key things. The first thing that I've observed is that my plan will never work. And I don't mean that the plan is bad, but while it remains my plan, it will never take. So the only way that an organisation will change to follow a plan is if the organisation believes that is now their plan. That's the plan that they want. So this shared vision, I think, is the first step. So the first thing that you have to do is to understand what they want, understand, in the military context, understand what I want or my government wants too, because it's two sides to the coin. In global health, sometimes it's a little bit easier in that it might only be one side to the coin, which is what do you need? But you've got to start with that, and then as a plan starts to shape, as you talk to people and you realise what it is that they need, what their resources are, what the opportunities are, what training people have had, what you may be able to provide, you come up with some kind of skeleton plan or some vision. And if they buy into that vision, then I think your program will work. As long as it remains your plan, it's not going to work. And so that shared vision as a starting point, I think, is absolutely critical. And that is difficult, I think, for doctors often, because prior to the point where we start getting involved in this kind of management, we are largely in it's our plan that we come up with and we then implement. Or we might tell some people, what we would like done from that position of responsibility. But as soon as you make it their plan, the whole construct changes. The responsibility changes, the drive and motivation for it becomes theirs, not yours. And I think the other thing is they then feel far more empowered to tell you which bits of the plan might work and which bits of the plan won't. And I think that's the other thing that's absolutely critical.
Yeah.
You've got to have that sense of humility where you might think you know what the solution is, and it might be the case that you do, but the people we're dealing with are not stupid. The people that we're dealing with are motivated, they're hardworking, they are trained to the maximum level within their environment, and they are usually clever, resourceful, imaginative people. So if it's blatantly obvious to you what the solution is, you've got to ask yourself, why wasn't it blatantly obvious to them? Now, sometimes it's because they just have never come across that concept, but more often than not, they've tried it already. And it didn't work. Yeah. And if you just say, do this, then they will, knowing that it didn't work last time, knowing that it won't work this time. They won't engage properly. And guess what? It won't work. There's usually a really good reason why it didn't work before. And certainly in Pakistan, we had lots and lots of conversations trying to understand one of their specific staffing issues. And it took us a while to realise that actually the reason they couldn't recruit into this post was because their current funding structure meant that to take on that post, the people involved would have to take a very significant pay cut. Now, until you fix that underlying problem, then the recruitment is never going to happen. As soon as you then go, right, okay, so now I understand, and you can go and talk to the other people who hold the key to that resource, suddenly you might unlock the problem that makes it feasible now when it wasn't feasible 3 or 4 years before. But if you haven't addressed the thing that made it fail before, then it's always going to fail again.
That's really useful advice, I think, particularly to any slightly junior medic feeling daunted, junior doctor feeling daunted by the task of having to move to rural settings to lead a clinic or hospital on their own. And I think that's right. Often these things have been tried before.
And that doesn't mean you can't help, but it means that you need to think more widely than just identifying a solution and telling people to do it.
Yes. And like you say, having the patience to sit and listen and the humility to accept that your plan may not be the best plan.
Yeah, absolutely. And certainly I fell into that trap again in Pakistan, actually, when we were looking at emergency medicine training. I was looking at the gap between what they had and where they wanted to be and thinking this is a huge gap to fill before we can reach a sort of start point. It was only when I had conversations with their Society of Emergency Medicine and asked them, I said, how have you addressed this elsewhere? Presumably you've had the same problem elsewhere. And they said to us, do you know what? I think you're putting your start bar too high. Sometimes you don't have to build up to a start point. Sometimes you start where you are and just be far more iterative and far more patient about it. And so don't reach for UK standards and think I must get there as quickly as possible. Think about what the country wants and needs, what's relevant to them, and ask them at the pace of change that they really want. And that's really valuable.
Yes, Arthur Ashe, wasn't it? Start where you are, use what you have, and do what you can.
Absolutely.
So, yeah, very true. Simon, thank you so much. I'm incredibly grateful to you for coming to talk to us. I think that will be immensely useful to all our listeners to hear about your experiences and the amazing things that you've managed to achieve as well through such an interesting career. I mean, from Ebola, Sudan, and through to COVID, given the career path that you've chosen, you couldn't really have picked a more fascinating time to work in that career path.
Been very lucky.
Yes. Well, I guess, yes, depending on your definition of luck. Yes, absolutely. No, thank you very much for that. And we look forward to speaking to you again soon.
I look forward to it too.
Thanks, Simon.
Cheers, Lucy.